My name is Kayla Ireland. Welcome to the Inside Scoop of Living with Cerebral Palsy, an extension of the Silver Speech Speaking Series. This is a talk show about spreading awareness about this common difference. April is Occupational Therapy Awareness Month. Today, we welcome Lorene Janowski and Lorene Menino, two highly skilled and sought-out occupational therapists at Hospital for Special Surgery in New York City, who treat cerebral palsy in an outpatient setting.
Thanks, Kayla. Welcome, everybody. I'm so excited to be here tonight. And it's such an honor. I've worked with Lorene for many, many years now, both at the hospital and independently. And Lorene, it is so wonderful to see a face with a name, finally. We also share clients together. And I am just so... I'm just so grateful to have you in my life, especially for my clients. And then I learned so much from you. Without physical therapy, occupational therapy, all the other disciplines, we get the most done with our clients. So I am so grateful to celebrate the end of your Occupational Therapy Month. And we're so looking forward to you answering all of our questions.
Thank you for having us. We are very much looking forward to kind of chatting, and certainly feel the same way. Having the best support for our clients and helping them to meet all of their goals and everything they'd love to do means that OT, PT, speech, and everybody else in the therapy team can be working together.
Amazing.
I want to say that those of us living with CP are always exploring and wanting to achieve independence, no matter what we are doing or whatever environment we are in. OT focuses on working towards independence and fine motor skills and alleviating sensory concerns. What sparked your interest in occupational therapy?
Well, I'll take that one first. I have to say, when I was in high school, I did a lot of observation and volunteer work in a hospital. And I'm the type of person that I really like things to be practical and realistic. Like figuring out what makes somebody tick, right? So, Katrina and Kayla, what makes you both tick is different than somebody else. So I said, I'm going to study something that's going to be rewarding but fulfilling for the children that I work with and the adults that I work with. And how can you individualize that to each particular person that you meet?
Lorene, that's so thoughtful. My mom was a teacher, and I had always been interested in the medical field. And I think OT really brings together the best of education and medical, and brings creativity to light in the realm of how do you help someone find the ways that they can be independent, enjoy what they want to do, and a lot of problem solving and working with other people. So I think all of those realms really guided me to OT.
And I have to say, with what Lorene and I do every day, we start out our day kind of not knowing what the day is going to hold. We can have people that are coming in that are walk-in patients. We can have babies. We can have teenagers. It varies so much. And there's not one day that we walk home saying, oh, this was so boring. It's so exciting. And we are constantly problem solving. I think that's such an important characteristic and a skill that we have, not just as people, but as therapists, and we have to look at things in a variety of different ways.
Yeah, I would say that you are the problem solvers with any of my clients, with behavior, with sensory, vision, fine motor, any of that. I'm always, thinking, oh, I have to call my OTs. They will know. They will always know what to do.
And also making it fun and interesting to the person, the individual.
Definitely.
Tell us what type of training is entailed in the degree of occupational therapy.
So I can start on this.
Lorene.
I can start on this. I have to say, I'm a bit older than Lorene. And when I went to school, it was a Bachelor of Science. So I graduated with a Bachelor of Science and then realized that in order to be proficient in what I'm doing, I needed to learn more. So eventually I moved on to a clinical doctorate, and the field right now is, it actually is a master level where you graduate now with a master's and then you have a choice to do a clinical doctorate or a PhD. So there's a lot of schooling involved, but that just shows how important the field is, and all the training that goes with it should make patients feel like very confident in the background of the people that they're working with. But I will say, education is so important, but like what Lorene and I were speaking about before, is like to have the skills, to have good communication skills, to be able to work well with a team, to be able to be a problem solver, to be flexible. Those are things that you're not taught in school, that you can have, but you further develop as a therapist. And they're just as important as knowing all the book stuff.
I would also say what is valuable about an OT, or probably any of the rehab domains from a learning perspective, is that our education balances things that we do in the classroom and also clinical practice. So Lorene was actually my fieldwork educator. So she was my supervisor at my first clinical rotation, and I learned so much from her. But everything that you learn in a book, you can walk into a clinic or a hospital or a school, and there's just so much more learning to do and so many more things to experience. And you learn from the people you work with, and also every client who comes in, you get something new to add to kind of your toolkit as you go.
Yeah, that's very true. I feel the same. I feel I got most of my experience and my knowledge from that hands-on training. And without HSS working there with you, I had no motor or sensory experience. And that changes the way I look at my clients now, is from a motor perspective versus, just like a speech perspective, or, it was basically very separated. And now it's, I look at the whole child or the whole adult from a different perspective. So I'm super grateful for that experience working with you both. So.
And Marci, that's a really good point, because when you look at the whole picture, we also do a lot of looking at posture, how a child is sitting, or, you as a speech therapist, when you're doing feeding or articulation, you're looking at the whole picture in regards to the appropriate chair that they're in, the table, it's all tied in together. Nothing works by itself.
Yes, exactly. And from a speech perspective, usually, we're the first line of defense. We get calls about speech because at 2 they're not speaking, but it happens way younger than that. From the gross motor perspective, that is huge for speech, but people don't think about that. So yeah, it's interesting too. I did want to cover that. OT does feeding, and we do feeding, and we do a lot of crossover. And some states OT does the feeding, and some states speech does the feeding. It's very crossover, very specific to each state. And so I think that's good to know, because I know Kayla has a lot of questions about that. And I was thinking to myself, well, some of it I do, and some of it the OT does. So it'll be great to hear those questions.
Describe occupational therapy to us in regards to working with patients with cerebral palsy.
It sounds like Dr. Selber in your previous interview kind of phrased it very well, that you can meet one person and you can meet 100 people who have this diagnosis, and everyone brings something different to the table. Everyone has different experiences and everybody presents differently. So Lorene and I work with many kids on our caseload who come in with this diagnosis, and each one of them may present very, very differently, and our goals look different, our treatment strategies look different. There might be some kind of underlying similarities or things that we might look for in an assessment, but you can meet one person or 100 people, and each person is their own individual.
Mm. How many CP patients have you seen?
Well, we work with a variety of types of children, and sometimes we work with children that don't necessarily have a diagnosis of CP, but they have similar characteristics to it. But with both of us, we do have a large percentage of children that we've seen, and again, they present so differently. We can even see children in the same family, either the same age or have more than one child in the same family with CP. So we really look at the whole picture, and we determine the type of, is it spasticity, is it hypotonicity, and all the different types. And Dr. Selber, I know, previously spoke about those a little bit more. And with individualized training and some of the continuing education courses that we've taken, there's actually different strategies to work with a variety of those different types of CP.
Yeah, I would have to, we have a lot of conversations about, professionals being afraid of CP. And so they turn CP down, or they don't want anything to do with that, or, oh, we have to send you somewhere else. And HSS, that's where you go, that's where you send them. And when I was working there, I had patients with CP, and I have some, not a lot in New York that I see. But, again, it is such a specialty. And I remember when I left, I think augmentative communication was just starting. You started a program for augmentative, and so that's a huge hole in speech, is finding the right augmentative device or being fitted for it. So, again, HSS is where you're going to have a good percentage of clients that have CP or, related or presenting like CP. So
I think being an orthopedic hospital, we have that musculoskeletal background, and we have an amazing team of physicians who also work in the pediatric realm and work with adults. So I think the team on both sides really helps to keep the program going and make sure that, every family really has kind of that lifelong tie to the rehab program and to their physicians.
I think you guys are going to get way busier once Dr. Selber gets off and running.
Well, if you look at the different areas that we can help children and young adults, we have a wheelchair clinic, we have augmentative communication, we have our orthopedic surgeons, and then we have our physiatrists. So, and then as well as occupational, physical, and speech therapy. So you look at that whole gamut, and it covers all the big areas that are in need of servicing all the areas that we need to really look at.
Now, does every patient have like a CP team? Because I came from Columbia, which was Weinberg Cerebral Palsy Center, who I was treated by Dr. Roy. And then when he retired, Dr. Selber took over. But then when a little birdie told me where Dr. Selber was going, I followed him to HSS and told everybody at Weinberg where he was going. So he's had a couple hundred patients follow him so far.
Yeah.
Mm-hmm.
Yeah. He sounds like he's really well loved by his patients.
He's such a down-to-earth guy. How laid back he is literally how laid back he is. And I love him because he's all about conservative treatment, and not a lot of people are like that. Mm-hmm. Like surgery is his last resort.
Mm-hmm.
And HSS, is a one-pop shop. You go and you are evaluated in different ways from different therapists, different needs and wants. So yeah, I would say that, it's an amazing place to get a thorough multidisciplinary, interdisciplinary, transdisciplinary workup. So it's the place.
Like Connecticut children.
Oh, like Connecticut Children's Hospital? Yeah, exactly.
Only you age out of that one. That's the only bad thing. It happened to me.
How much classroom time did you get in school about CP?
I can speak on behalf of, a while ago when I had my Bachelor of Science, there wasn't as much research as there is now at the time. And just like anything that you learn in school, you really have to do it. You have to learn, you have to make mistakes, and you have to want to get better at it. So my recommendation for new therapists and for therapists that are still in school is to further your education with continuing education and certification courses, because CP is a great area to work with, and it's a challenge, and it's to be a good problem solver, you have to keep at it, and you have to keep figuring out what is best for your patients.
So let's talk about daily living skills. I personally find it interesting that no one skill is straightforward. For example, self-care. The most basic self-care things like eating and taking myself to the bathroom aren't always the most efficient for me to do. However, sometimes we do take 20 minutes to have me independently walk myself to the bathroom, pull my pants down and everything else. And I laugh or giggle through it all.
It's such good motivation to be able to feel like you've had that accomplishment, that you're able to do something on your own. And I think Lorene and I every day are looking to kind of celebrate the big things and the little wins along the way, and using that problem solving mind to figure out what is it that's motivating for you. Maybe for you, it's being able to get dressed or use the bathroom. And maybe for someone else, it's to be able to feed themselves or to socialize with friends. And everybody has that thing that they're like, yes, it's going to take me longer to do, or I have to do it a different way. Or sometimes I need help and sometimes I do it by myself, but you have to find what that thing is that's motivating. And then our job as OTs is, how do we focus on that? And what are the skills that are going to build up to it? And looking at the task itself, like you said, even the simplest of self-care things are so complex, and you could break them down into 100 different parts and steps and figure out each one along the way to give you that success.
That's also a really good point, Lauren, because you have to have that internal motivation and that drive to want to do it, right? So if somebody doesn't want to be an independent dresser, if that's not important to them, that's going to be hard to work on. So if you have that inner drive to want to do it, you can make that limitation an opportunity and become a great area to work on, and to work on some adaptations and some changes with your personal occupational therapist. And that's why it's so important to work with, to have OTs in a clinic setting in the school, but also the home, because working in your natural environment, your own bathroom, your own bed, is very different than working in a place that's not used to what you're doing.
Yeah, for sure. I love, I've worked with Kayla when she was 3 years old. She was one of my first clients as a speech therapist. And I saw her drive, immediately, and knew that no matter what skill it was going to be, that it was going to, it was going to happen some way or another at some level, right? So I just, we talk about this all the time, we talk about reasonable skill, efficient skill, effective skill, what does that mean? But it's, I love that I like to go into homes, go into classrooms, go into, whatever environment they're in to problem solve and help them. But, I've just seen, and then here I am, she was 3, and now 20 years later or more, I'm not going to age myself, but, it's just amazing to me how far she's come, because I missed all those years with her because I moved back to New York. But it's so cool to see what the OTs did, what the physical therapists did to work with her and get her to where she is, and speech and feeding. So I'm excited to share with you some of the pictures she wanted to show you.
And as important as those therapists were, Kayla, it came from you, that grit and inner strength. That was all you.
Yep.
You can't
The
teach
willpower.
that. You can't teach that.
Whoa, look at that muscle. Look at that bicep.
You can't teach that.
And not teach that to anybody. A teenager, an older person, anybody.
Self-feeding isn't a realistic skill for me, but I feed myself Twizzlers.
Oh, excellent choice.
I'm going to share with you her eating her Twizzler. If I can find it here. Let's see. And that's not the one. Here we go. Can you see that? Hold on. Sorry about that. Here we go. Kayla's eating her Twizzlers. There she goes. Amazing.
Yeah. And those were the hard ones. Those were the pull-and peels, it looked like. Lorene and I would love that from a fine motor coordination standpoint. I think it's so interesting also how you can have 3 different disciplines, OT, PT, and speech, and we all can look at something so differently from our training and our backgrounds and put it together. The physical therapist may look at the posture when you're eating the Twizzler. The speech therapist is looking at the feeding aspect, and then the OT is looking at how you peel it apart. So, and they're all so important together, but how we all have our certain critical eye to blend it together. And that's why all 3 disciplines are really important, an important piece of the puzzle.
I don't pull apart.
Oh, you go right in. You know what? I would do the same thing.
That's definitely the way I eat them too. Who has time to peel them apart?
Oh, exactly.
No way.
Too much work.
That's hysterical.
Every time I drink, I need a cup with a lid, straw, and handle to hold. However, that doesn't mean that I don't have a zillion cups. For instance, since the pandemic, I have been drinking coffee.
Lots of coffee.
Course, yes, I have acquired coffee cups that meet my motor needs.
She's got a lot of cups. I did show you some. Let me see if I can bring them up again. There you go. Wait, how come it didn't do it? You know me. It's not working. Uh-oh.
Yeah.
There we go.
I see them.
You
You've
see
got
it?
quite the collection.
Look at that. Lots of cups.
And all the variety of straws. And the handles.
You do? Wow, girl. You're the
You
cup girl.
How do you assess the need for a special cup?
So one of the things that we would look at is a person's hand skills, also how much control they have. there are certain types of cups. I didn't see it on one of the cups that you have, but there's a cutout that I actually used for some of my older patients, especially patients with a degenerative condition that lose their ability to tip their head back. And there's a cutout part of a cup. So it's called a nosy cup. Your nose goes into the hole, and instead of having to tip your head back, you just adjust the cup. So it really depends. It comes back to that individuality to see what the child needs.
And I think so many people are so creative and have built things for themselves or their family members and then made them more commercially available. So the collection of coffee cups you've acquired really kind of seems to speak to that there are so many things out there, and sometimes it's a little bit of trial and error, seeing what works, adjusting things, reading things up, and then trying to see if you could find something that mimics that. But you guys are probably the expert on finding what works and what works for you, and our role is to find everything that's out there and kind of provide the resources and say, could this work? Should we try this? This didn't work. Let's find something else.
Let's discuss sensory issues. I don't have diagnosed sensory processing issues, but have a few interesting things. If I see a pen or pencil, I tend to hold it and fidget with it. And even though I have gained good head and neck control, I still don't like hoods or hoodies. It doesn't happen as often now, but sometimes when people brush my hair, my neck is sensitive. I have an over-exaggerated reflex. Is that considered sensory?
So, in regards to cerebral palsy, you have fluctuating muscle tones. So sometimes those muscles, they work too hard and it's hard to shut them off. So our sensory system, it helps us interpret different types of information. So sound, touch, taste, smell. And then you also have other hidden senses that are not so clear cut. They're more of the position of where your joints are in space and where your muscles are. So, it's fair to say that we all have some of us are sensory seeking, some of us are sensory avoiding in certain areas and then change in other areas. So it's quite a combination of how our sensory system works with how our muscles and our joints work throughout our body. So they're very interrelated.
Yeah, it's interesting because I lost my hearing. I took medication and I lost my hearing. I have a sensory neural hearing loss, and loud noises and, the city has become so overwhelming. And who would think that you have a hearing loss, like you can't hear things? Well, actually, things are exacerbated depending on where the sound comes from. Is it like in a low frequency or is it in a high frequency? And I can't handle it, so I've definitely developed sensory issues in my old age. So, it's true that your sensory system is constantly adapting, constantly changing, or like a bad food experience. You might never go back to that food. That's a sensory. And I think you asked about your reflex, your exaggerated reflex. And yeah, I mean, that could be sensory depending on what food you're eating or what utensil you're putting in your mouth. That could definitely be sensory, and then just reflex, it's a reflex. So it's obviously to be sensitive. Do you guys agree? You agree? Yeah.
Oh yes, I think Marci, that was a great way of phrasing it, because it's never the same. You're always changing on age, and also in different environments. So you could be living in a quiet environment versus a loud one, and that your body reacts very differently. Many times what we'll see is children act very differently in school than at home, depending on what their experiences are.
And it's all about adaptation and learning, whether it's just natural aging across the lifespan or what environment you're in. Your body is constantly trying to take in information from all of the sensory systems. And when you have a change in one of those systems, the information you're getting to process is different. So you may be working on kind of different information than you were used to a few months ago or a few years ago. And your body really has to adjust and learn and be flexible. And integrate that new information. And it takes a lot to put all of that information together, process it, and create a response, and then adapt that response over time to continue to be successful or have some control in your own environment.
Yeah. And I've been teaching advocacy for my clients on, right away coming out and saying, listen, I have hearing loss. I can't hear. So if I'm not paying attention at the dinner table or it's not because I'm being rude, it's because I can't hear you. Or, we had an interview with Bethany Bookins, and she was telling us she can't, if there's a popping sound or a rustling, her whole body goes into shock. So she let us know that before we did the interview. And that's super helpful. In any client I have, if it's a stuttering client, right away saying, listen, I stutter, no big deal, just in case I get stuck on a word. So, communication is super important in these times of sensory issues or difficulties.
I find that we also talk a lot with caregivers and parents and families to recognize some of those things, that especially for some children who may not be able to communicate that verbally, for someone who's with them to look out for some things, or think of ways that you can be considerate and either ask about it or, use your body and your movements to anticipate something that could be startling or unexpected. I know, like with feeding, we had a family who sat on the side of the child, and every time the spoon came in from the side, it was like, where did this come from? Right? So just that sensory component that so impacted the feeding and eating and being able to take in food and appropriately swallow, something that we wouldn't have necessarily recognized, but was OT and speech working together to kind of adjust the setup of activities and how parents and caregivers are interacting with the kids in their family.
Unpredictable sound make me jump.
Yeah, unpredictable sounds can startle you as well. But, you also have to think about what's working and what's not working. Do you need to dim the lights to make it more calm? Do the people around you have to lower their voices? Do you have to play soft music in the background? Those are, or it could be the opposite, where you need to have more stimulation. You need to have loud sounds, or the TV playing in the background for loud noise. Everyone needs something different. It was very interesting. Many years ago, I had gone for a certification in working with children with cerebral palsy, and something called NDT. And I'll never forget, the speech therapist who was giving the course had said, we all think about doing feeding in a quiet environment for what the child needs. But you have to realize that in the school setting, they're in a very busy environment, and they have to get used to that. And actually, some children need that busy environment to help them. It's not necessarily a quiet thing. So it goes back to that variability and that what each child needs and how everyone is so different.
Absolutely.
And it really it made me think about, wow, I didn't realize it had to, that more stimulation for some children is okay, is better.
Absolutely.
Lastly, let's talk about augmentative and assistive technology. How do you determine the appropriate AAC device for a client?
So at HSS, our assistive technology program, we have an occupational therapist and a speech therapist, and we really work together, especially when it comes to speech and AAC, to determine what the best path is. I think some of the big considerations we look at are physically accessing speech. So is it more of like an iPad or a speech generating device? Is it a picture system? Is it switches? And then how is the client going to access that? Is it using a part of the body? Is it using eye gaze or head control? And then we also look at things like what's going to work in their natural environment. So at home and in school, what's going to be carried over, what works best for the client and their family and their caregivers, and what's realistic, what's going to give you the best outcome in all of those settings, and what's motivating, like what do you want to use? You don't want to use pictures? Great. What's a different way that we can approach it? You don't want to have to attach a big tray table to your chair, so switches aren't the best thing, or you really like to be able to communicate these 5 things that are part of your daily routine, but some other things aren't as important. What do we need to set up so that you have the best outcome for what you're motivated and what you have to do in your daily life?
And, you know, in regards to that also is that you do need a full, thorough evaluation. And you want to also ask, besides the child, the family, some of what their personal goals are. And you really have to try it out over time, because what you think may work may not work. And you know, sometimes they're maybe the best well-intentioned, and it just is not right for that particular child. I have some background noise here. You can tell this is New York City. Right? But, you know, sometimes depending on the third party provider or who's ever going to be covering the device, they want to show that who's ever using it, it's successful, and then it's going to help them over time. And you have to prove that to them so that they will approve it in regards to what the cost is.
Oh, I deal with that on a daily. I do authorizations for insurance companies, and they are terrible.
That's, I think, what Lorene said. You know, it's having people around you and on your team who are informed, and then being able to have support and resources so you can kind of learn to advocate for yourself and know what's out there, and know where to look for information or who to ask the questions to, so that every opportunity you have is out there, and having a thorough assessment and having, you know, the resources to trial things to be able to justify makes such a difference for our clients.
I've been working with a child who I was able to set up a augmentative evaluation, and we had a loaner for 2 weeks, but 2 weeks is not a long time. And because of COVID, the availability of these devices to loan are not available. So you know, I am not an augmentative, it's not my specialty, but I've used so many with my clients that I'm sort of same thing, trial and error. But you know, consistency, people of all of the whole team should be using it. You know, and that's what we are struggling with this team. Now the device went away, and I showed up today to work with the client, and I was lost, because I'm like, I was having so much fun. We were both getting into it, and now it's gone. So, you know, we have to figure out how, you know, what is the best device? What is the most cost effective? What is the most, you know, do we bring it to school? Do we not bring it to school? When is she going to use it? You know, and they're very expensive. So, so it's a learning curve for me, but I enjoy, you know, trying to get my clients the right device that they need. So I'll be calling you.
It's definitely a learning curve, and it's something that, you know, same as you go for continuing education and to further your understanding of different areas, I think it's a lot of self-education and trial and error, and working with clients who can give you feedback and help with that problem-solving process, and knowing when to ask for help. I have definitely reached out to vendors and to our speech therapist and said, I'm having trouble figuring out what the best way to do this part of the task would be, or I'm really thinking about how to make sure that they have access at home or school. What's the best way to set this up or do this or problem solve or change something so that I'm giving the right information and I have as much information as I can share.
Yeah. And as a speech therapist and knowing what the OT is going to look for, and anticipating from working with you both, I know, okay, this child had, her hand was getting in the way of, so she might need a key guard, or I was working with her just on the waiting, the cause effect. I press a button, I have to wait till the action is finished because she's young. She's only like under 2, or she's going to be 3. So, teaching her to wait, press, okay, wait again. I mean, simple, even going back before pictures, it's like teaching her how to use the device. Was interesting to me because I don't think I was ever, Kayla and I had an opportunity to use a device together, but I hadn't done it in so long. So it was super helpful to know, okay, what's the OT gonna look at here, or the vision. So she always was going to the corner and she hasn't had her eyes checked. And I keep saying, get your eye, we need to get the eyes checked so we can make sure she's seeing the whole board, because it's hitting the corner. So, those are things that if I wasn't working with my favorite OTs, I wouldn't know to even suggest that. So thank you.
And then it's also setting up, realistic expectations, because there are some people that really want it very basic and simple, that doing the higher level technology is just not going to work for them or their family. So it's also doing that trial and error to see, do you start with the basics and then get more complicated, versus do we start complicated and then, as we progress, see what we need. And also technology is always changing. And that's why it's so helpful to work with an OT and a speech therapist, and then also the vendor that works with these products all the time, because it really is constantly changing for the better.
Yeah, for sure.
Until sophomore year of high school, we attempted to use Dynavox. It was constantly freezing. My special education teacher saw the terrible frustrations and knew that I had an iPad at home. I brought it in. I switched to ProLoquo to go on my 9.4-inch iPad because that was the app all my friends who use iPads at school used. It was a no-brainer. In summer of 2016, I had my last AAC evaluation. They officially switched me to the iPad I have now, that is 12.9-inch.
Yeah, so it's come a long way since we worked together. First we had a communication book, a piece of paper, and then, we ordered the Dynavox for her, but it was frustrating for the therapist too. And I always say, technology for basic video games is like incredible, like the graphics and this and that. And, these devices, it was slow coming, but now, like you said, computers keep changing and for the best. So it's just interesting how far it's come, but still how far it needs to go to help communication.
That's, I think, the great thing about more technology and more people accessing things is how many technology companies like Google and Apple and Microsoft are building in accessibility features to their devices, so that you can use something that all your friends are using, or your systems are integrated and you can use smart home technology. There's so many things that people, for any reason that they might want to change things or make life easier or have an adjustment, have created and now share. And it really helps to kind of move things forward and make everything more accessible, and let you use your technology across platforms, because your device and your iPad and your app are one way that you get to interact with people and share all of the great things that you have to say, and let you communicate and engage with other people.
See, if they see our podcast, we might give them ideas on creating a decent device. Kayla, you should reach out to Apple. They probably would listen.
But Marci, well, you just spoke a little bit before, Marci, about how important advocacy is. And Kayla, I think you did an excellent job about advocating for yourself with your communication device that you were referring to before. So you advocated what the best fit for you was, and look how far you've come with it.
And hopefully up with my voice.
Yeah, so we had Dr. Patel on, and she was actually, when I was at Columbia, she interviewed for a professor. And I remember she presented her research, and basically she's trying to create natural voices for clients and their augmentative devices. So it's amazing. She takes regular voices and matches it with their stature, height, weight, and has, us put it into a system. And then she takes the individual with cerebral palsy or whoever and has them use their sounds or whatever, however they're communicating. And then she meshes them together.
That's incredible.
And creates a voice. So, we learned a lot from her, and, just so many cool inventions and research and new ideas.
That sounds very similar to what voice banking is, with
that's what it is.
Patients with I also work with patients with ALS. So there's a certain time frame where you can save the voice, and as these patients lose their speech, they can still use the augmentative communication device with their own voice, and it's quite incredible. And it's really, you don't realize how important it is until you need to.
Exactly.
I have 2 comments about switching devices. I don't use the pre-programmed grids that automatically come on ProLoc or 2Go because it's too limiting in vocabulary. It reminded me of the Dynavox. When I first tried this iPad, I had to use the split keyboard, but I don't remember using that for long. I consider myself left-handed for signing, driving my wheelchair, holding a pen, etc. because it's my stronger, less affected hand. However, I prefer to hold my cup or use a computer joystick on my right side. How do you go about evaluating dominant-handedness?
So, early on when we look at development, we look at, if we're working with a young child, we want to make sure at an early age they're using both hands together. So when we see a child at an early age using one side more than the other, that's where we do recommend getting some type of service. As you get older and as you develop over time, as you use your hands for more things, you're going to have one hand that's stronger at certain things and one hand that's stronger at something else. And just like where you have the joystick on the wheelchair versus how you type can be completely different. So it's assessing to see what works best for you. And if one hand serves as a stabilizer, and one hand serves as more of the manipulator that has more of the fine motor and more of the function of movements, we look at it from that standpoint. But it's just important early on that those are some of the things that Lorene and I will look out for to see if we're concerned when we're working with a young child, to see if they're using one hand too much early on, where we really want to see both hands working together.
Is it common to have some situations where you prefer to use your weaker hand?
I think you're lucky you couldn't figure out which one works for which, but I know that there are some people, like my brother likes playing hockey, and he plays hockey righty because that's how my dad taught him, but he writes, he eats his food, everything else with his left hand.
Wow.
Yeah, that's how I am in sports too. I bat left, throw right, kick left. I'm all over the place in handedness.
It's great. You're working on both sides of your brain.
That's it.
While my hands were small, I used the normal joystick, but as my hands grew, I now use the small ball instead for my computer, but not for my wheelchair. Can you please elaborate on why adaptive joysticks are used?
I think you kind of touched on it. So it just gives you a different way to access a system that maybe if you have a different grasp pattern that works most efficiently for you, it's just another way to access a device, whether it's a wheelchair or a computer or a game. And we really want to make sure that all of our clients know what's out there and try things out. And like you said, over time, what hand you use or what kind of refined pattern you use or where it needs to be set up for you might be different. And I think that's a reason that we would look at changing or using something new as well.
Please talk to us about how motor planning varies depending on the task.
So motor planning is, it's a complicated thing where your brain is working to move. And sometimes we have to think about it more, and sometimes it's more natural. So that motor planning piece is so important to develop. And those are all skills that you work on with your OT, your PT, and your speech therapist. One of the things that I love with motor planning is I love when I'm working with especially younger children is having them touch and feel a variety of different shapes and textures and having them reach for things and put certain things away. This way that they can motor plan, I'm going to reach for something that may be a square or a triangle. But how am I going to shape my hand differently to use something that's a different shape? And how am I going to figure out how to pick it up and put it onto a target? So those are all areas that are important to work on. And then like practicing it in those activities of daily living, those everyday skills of motor planning on how you're going to put shampoo on your hand to wash your hair, or how are you going to stab food with a fork to bring it to your mouth. Those are all very realistic and everyday areas that we motor plan that we don't even realize what we're doing.
Yeah. And I find that, oh, sorry, you go.
I was going to say, Kayla, you brought up before that how complex even self-care tasks can be. It's all of those little motor plans that come in to create this bigger pattern to accomplish a task.
Yeah. And I also see that globally, like if a child has motor planning difficulties from a gross motor perspective or an OT perspective, it carries over a lot of times into speech. So it's a global area to work on.
Please talk about the different tools that come with joysticks. Is it typical to swap these out as you grow?
And Kayla,
Absolutely.
and you're talking about the joystick on your wheelchair, correct? Or the joystick on the computer? Both?
Both. I think there are so many different types of products out there that even though joystick you'd use for your wheelchair or your computer could be different. And as you spoke to before, as you age, or as you need something for a different purpose, or as you refine your movement and your motor plan as to what's most efficient for you, I think those would all be reasons to try something new or modify what you have.
In addition to an adaptive joystick, I used a guarded keyboard to help with accuracy. What else does guarded keyboards help with?
I think, like you said, accuracy. I think, as we spoke to before, that cause and effect, being able to bring your finger or whatever your access point is for some kind of technology or touchscreen to the surface. And it kind of helps give a little bit of a guide. It can also be, if something with vision, it's a tactile cue. It really directs you into the space. So I think for accuracy, for control, for more multisensory feedback, it's a great tool, and it comes in lots of different sizes. And I think it's been a really helpful thing, especially with people who even are just learning and first starting to use a device, that it really gets them to the space that they're trying to go for that cause and effect feedback.
Mm. People who know me know that I am stubborn. On my Dynavox and laptops, I like to disregard. As a result of this, we have many laptops that are missing keys because I pop them off due to how rough my movements are.
Kayla, I just have to say
that
I just have to say, stubborn, we don't like the word stubborn. It's called perseverance. You have perseverance. You do not give up.
I can proudly say that I have had the same laptop since January 2019 and haven't popped any keys off yet. Hopefully mentioning that doesn't jinx me.
Funny.
How does OT help with spasticity and other movement disorders?
So there are some pharmacological components that physiatrists can help with in regards to Botox and intrathecal baclofen pumps. But as occupational therapists, we do a lot of other exercises such as weight bearing. We do some other strategies in trying to help normalize some of the movement patterns using a variety of different types of benches and balls and bolsters that help to kind of quiet down that muscle tone while we're trying to work on facilitating some movement patterns.
I have been able to avoid medication and other options so far.
That's wonderful.
And you know what, Kayla, there's also some other areas that we look at. I know you're very into horseback riding, but also aquatic therapy is a wonderful adjunct to working with land-based therapy. And also there are several camps. In fact, there's a camp at NYU offered this summer that works on constraint-induced, where you, for primarily with patients with cerebral palsy that have hemiplegia, so one side of the body is affected, they're forcing they're limiting the stronger hand and forcing the weaker hand to do as many activities as the stronger hand would. And there's also a camp at Columbia that focuses on using both hands together, the habit program. So those are also additional adjuncts to your typical physical and occupational therapy and speech therapy, as well as some of those other areas that we talked about.
Wow, thank you so much. That's really important information to get out there. Especially for our podcast, or to let people know that's out there. That's amazing.
Right.
All right, Kay.
Please show setup.
Say again? I didn't understand that one.
Please show setup.
I'm sorry, it's unintelligible.
Please show picture of equipment.
Got it. Thank you. Okay. Know me with my technology. All right, what's happening?
There
I
it
don't
is.
have it. You can see it?
Yes, we can.
There you go. Can you see that one?
Yeah,
Yeah.
it's very clear.
Okay, good. Sorry about that. There you go. All right, Kay. Finish it up.
Even though I can write my name in big letters independently, my signature is my fancy K. Think how important and rewarding it is to give cognitive consent as an adult.
That's an excellent way to end our episode, for sure.
Lastly, thank you for doing this segment with us. It was great to have you on. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.
Thank you so much. It was such a pleasure having you on.
So nice meeting you both.
Yeah, so nice to meet you. Thank you for everything and for all your feedback along the way. We appreciate it.
Yeah, we'll need to we will need to go out for some dinner.
So we just wanted to thank you again for inviting both Lorene and myself, and also for being such a good advocate for not only you, but for everybody else watching. You don't realize all the impact that all of you are doing. And
Yeah,
you're the voice for other people that don't have one, or that are just maybe a little bit more quiet. So you're really spreading your wings to help everybody else.
Yeah, I think it's just making people aware too, because a lot of people, like for me, I mean, I'm ambulatory. I got my driver's license in my 40s, but a lot of people don't realize that I have CP, and I'm actually quadriplegic, but my upper body is obviously stronger than my lower body. And they were like, "Oh, I just thought you limped," but and it's been a long time since I've actually seen I think since high school, since I've seen Marci. So I've had several surgeries since I have seen her. So I'm excited to see her again to see if she can see the difference.
Yeah, we went to high school. We went to elementary school together.
Yeah, I remember you saying that.
And we used to ski together on the ski slopes, and we're really good friends. So it's been so long. So it's so great. I'm so grateful to reconnect everybody and introduce new people.
Right.
So
you're so good at that, Marci. That's like that's your superpower.
Yeah, well, I'm grateful. I'm grateful for you. I'm grateful for Hospital for Special Surgery. I'm grateful for speech language pathology. And the pandemic, very sad time in our lives, but it also changed the way we do therapy. It changes the way we communicate with parents, patients. And we're really enjoying this whole process. So thanks again for joining us.
Just like how motor planning is a complex topic.
Well said. Well said.
Yeah, we could have talked all night about this.
Yeah. Well,
thank
you. Nice meeting you both.
You're
Unfortunately,
welcome.
I go to the city branch often because I see him in White Plains because I live in Danbury. So White Plains is actually 40 minutes from me.
That's a lot more convenient. Traffic anytime you can.
I drive myself to the city because I was having a panic attack being in the passenger seat.
Yeah.
So funny. Well, thanks again, and go get yourself some dinner, relax.